and welcome to this session with Dr. Mildred Solomon, President of the Hastings Center. The center, there's a picture of the building, is an independent nonprofit organization now celebrating its 50th anniversary, and it was central really to the creation of the field of bioethics 50 years ago in 1969. It's located in Garrison, New York. It was started in Hastings on Hudson, but it now lives in Garrison. And we overlook at a place that overlooks the Hudson River. If you can advance the slide, we got a little bit of our view. West Point is we're basically across from West Point, where we're located. The Hastings Center publishes 2 of the leading journals in the field, and its small cadre of scholars and their projects over the years have had a deep influence on topics such as end-of-life care, AIDS care, research with human subjects, the wise use of new technologies such as genetic engineering. The wide array of implications of an aging society is a current emphasis, as are issues involving racism and health disparities. The center has been extraordinarily active in developing guidance for the COVID pandemic and providing a forum in which many controversial issues are discussed. And that's what Millie is going to talk about today. Before I turn it over to her, I would be remiss as board chair if I didn't mention that a substantial share of our budget, about 40%, comes from donations from individuals and organizations that want to support our work. There's plenty of information on the website, thehastingscenter.org. I'm going to put a URL up at the end of the program. This event is an example of the Hastings Center's commitment to public engagement. We believe that issues such as important as these that we're going to be discussing today should not just be the province of experts. Hastings has been doing more and more in the public square through events like this. If you wish to be more involved with a range of interesting issues that the Hastings Center tackles, you can sign up for the weekly newsletter, which includes information about upcoming events. As I said, we'll show the URL at the end of the hour, as well as contact information. You can also write to me at the address in the club's directory. One bit about logistics. Dr. Solomon will speak for about 15 minutes or so, and then I'll pose a few questions. You can ask questions by typing them into the chat box that's at the bottom of the screen. Some of you may see an option to raise your hand, but we will only be taking questions through the chat. Millie and I will stop occasionally during the hour to address questions from viewers as they come in. We've asked Isabel Bolo, a project manager at the center, to field and synthesize the questions. So I'll be handing things off to her from time to time. And with that, I'll turn it over to Millie Solomon and a discussion of ethical issues presented by the pandemic. Millie's a social scientist who studies values and ethical questions as they arise in science and health. Her scholarship has focused primarily on improving end-of-life care and protection of human research participants. She's been the president of the Hastings Center since 2012, and in that time has enlarged Hastings' research portfolio and its focus on public engagement and public programming. She also runs a fellowship program at the Harvard Medical School, where she has mentored over 200 physicians and healthcare professionals in bioethics. And so I'll turn it over to Millie at this point.
Thank you, Brad. It's really a special treat for me to be doing this together with you and Ellen. And I want to thank Ellen for the invitation and for proposing this title, Who Should Live and Whom Should We Let Die? It's a provocative title, Ellen, and maybe even more provocative than it might have first seemed. When we first hear that phrase, I imagine that most of us think about rationing, about the shortage of scarce resources in a pandemic, shortage of personal protective equipment, masks and gowns, the shortage of ventilators. Scarcity and the need to ration important resources are in fact very common in pandemics, and certainly they are one of the most challenging aspects of this pandemic. And I promise to address a wide variety of rationing concerns in the course of this hour. But I would like to start further back by interrogating that question, whom should we let die? Letting suggests we're allowing something to happen, that part of what we're experiencing is caused or facilitated or amplified by the things that we humans do or don't do. Allowing or letting are terms that suggest that people have some moral responsibility for the circumstances in which they find themselves. For better and for worse, that's very true of this pandemic. Human behavior has contributed mightily to the emergence of this virus and to its mismanagement. But human behavior is also essential to its resolution and to rebuilding our world better afterwards. So I'd like you to see this talk as a talk about pandemic ethics and human responsibility. To do that, I'm going to set a pretty big table. I'm going to define 3 courses, if you will, 3 large areas where I hope we'll recognize and act on our ethical responsibilities. The first one is broad. It has to do with the relationship to the environment, our relationship to the environment, and the human contributions to climate change and to our environmental destruction that have played a big role in this pandemic and in other diseases caused by zoonotic viruses. SARS-CoV-2, the virus that causes COVID-19, is a zoonotic virus. That kind of virus is one that jumps from animals to humans. Very often, the animal vector are bats, especially fruit bats. We know SARS originated when bats and other wild animals, SARS-CoV-2 that is, when they were sold in close proximity to human beings in a very congested market. Let's remember that Ebola was also a human disease that occurred also when a virus jumped from bats to humans. And it's now understood that the first patient to contract Ebola in the West African epidemic of 2014 was a small boy who was sitting in the hollow of a tree on the edge of a forest in Guinea. A forest canopy had just been mowed down. Massive deforestation of the adjoining large landmass dislodged the bats from their home. They flew to the nearby village where that little boy sat unknowingly and contracted the virus that the bats carried. Viruses that travel from wild animals to humans pose a dramatic risk to human health, and they're going to keep coming as long as we continue encroaching on natural habitats and failing to respond adequately to climate change. So when we talk about allowing to die, let's start there. Second point, one of the most distressing aspects of allowing or letting to die in this particular pandemic is its disproportionate burden on communities of color. As Ellen said, the statistics tell the story. The next slide shows that African Americans are dying at almost 4 times the rate of white Americans. It differs in different cities, but this is on average nationally. Native Americans are dying at a very similar rate, 3.4 times that of white Americans, and the Latino population at 3.2 times the rate. Now, there are numerous reasons for these disparities. The higher COVID-19 infection rate for people of color isn't really a surprise, since African Americans and Latino persons make up a large percentage of the low-wage essential workers who are less likely to work from home and more likely to travel and work in public places where they can contract the virus. Second, in the United States, people of color are far more likely to have serious underlying chronic conditions. And we know that having underlying chronic conditions puts us at higher risk of death from COVID. In fact, on average, Black men and women both develop progressive life-threatening diseases about 10 years earlier than white men and women. Things like diabetes or cardiovascular disease. And that's why they have a much shorter life expectancy, because they're getting chronic conditions at least 10 years earlier. In Washington, D.C., Black men die on average 15 years before white men, and Black women about 9 years before white women. And it's this early onset of chronic illness, as I say, that is responsible for that. So I'm going to stop sharing my slides for a minute and confront the next question. And Ellen asked this in her introduction. What causes that extra burden of chronic illness? You know, it might be easy to believe that the causes are socioeconomic, like poverty, or personal behaviors linked to lifestyle or genetics. And of course, all of those factors do play a role. But over the last 2 decades, there's been a large and rigorous public health literature documenting that social factors well beyond a person's individual control determine these outcomes. And one of the most powerful social determinants is racism itself. Not only individual racism in the traditional common sense that we use that word so frequently to indicate individual level bias or hatred towards others, but structural racism, systemic racism, which includes things like the history of redlining mortgages or discriminatory zoning regulations, which led to residential segregation. In turn, residential segregation led to poorer schools, and that in turn led to fewer opportunities for well-paying jobs when children don't have an education equal to the opportunities that may be available to others. Research has also shown that the stress of living in unhealthy housing stock, lead-contaminated homes, food deserts, and places without trees or safe recreational opportunities takes a direct toll on the human body, and the pathways of how these social and environmental factors actually affect the human body have been well mapped out. There have also been numerous studies showing that person-to-person discrimination, microaggressions, create toxic stress that creates chronic inflammation that leads to premature aging and the early onset of chronic illness. So if we truly want to consider whom we are letting die, we need to consider the ethical imperative of addressing these social determinants of ill health. And 3, the third course I promised. As I mentioned at the start, pandemics often create scarcities of all kinds. In this pandemic, some scarcities were wholly unnecessary, and they were the consequence of government failure. We've known for more than a decade that the world was extremely vulnerable to new viruses, actually longer than a decade. And numerous organizations, including the National Academy of Medicine and the CDC, as well as state departments of health and hospital systems all across the country, developed plans to ensure adequate supplies of vital resources. But these plans were never properly funded, and even when supplies were ordered, they weren't stored in a way that protected them, so they were allowed to languish and became unusable. So that's the first point I wanted to make. There are preventable scarcities, and we failed to do that. Another very current example is the paucity we still have of tests and the fiendishly long waits we have for test results. All of this was predictable and preventable. But there are some forms of scarcity that are not avoidable, that will happen. And we do have to think carefully about how to allocate those precious resources when there just aren't going to be enough for all the people who would be clinically eligible from them and likely to benefit from them. Those responsible for emergency preparedness are places like state departments of public health, health systems, and at the federal level, the CDC, have identified 3 levels of care: usual standards, contingency standards, and crisis standards. Contingency standards are invoked when there's shortages, but you can do a workaround. You can use a substitute product, or you can time things a little bit differently, and everybody will eventually get what they need. It just won't happen in the perfect usual way. Crisis standards of care are invoked, and most often they are invoked by the governors of states. They get invoked when it is clear that there are no more workarounds, that there just are not enough of some essential resource for all those likely to benefit. Now, in the early months of this pandemic, we thought we were going to have to invoke crisis standards of care for ventilators. They were certainly scarce, but the fear that we would have to start making these kind of terrible, tragic choices actually motivated people to solve the problem. And we did produce more ventilators, and we found productive ways to share them within a state where they could move them quickly to where they were needed. So in the end, crisis standards of care at least officially, there probably was some rationing going on in some places, but officially it was never invoked for ventilators. But it was this expectation of shortage that got everybody scurrying to develop these guidelines. And what happened is a great deal of work by healthcare professionals, by bioethicists, by state departments of public health that started coalescing some aligned thinking, some thinking emerged that was, I would say, converged, and guidelines emerged that were originally designed for ventilators, but that are equally useful for other kinds of resource shortages. For example, right now we are already seeing a shortage of remdesivir. Now, remdesivir hasn't been proven effective for anything yet, but there is some evidence it might shorten the course of COVID-19. And so the FDA has granted an emergency use authorization, which allows us to use it even before its efficacy has been proven. And remdesivir has been sent out to hospitals, but already it's very clear there's not enough. For example, the University of Pittsburgh has about what they need for about 25% of the people that they think would be eligible for its use. And I know that to be the case also in Massachusetts. So the thinking that we did on ventilators is going to be very relevant for the thinking on other resources like remdesivir. And so I thought I would, in the last few minutes of my presentation, is describe, kind of characterize for you what these rationing schemes that have been developed that now exist in most health systems, how they're structured. They're pretty consistent, and they have two primary goals. I do have a slide for this. We can just share the screen. The first
We're not
is
seeing a complete slide, Isabel, for some reason.
well, it's built.
Oh, there we go. Okay.
Does it show maximize the benefit to population health?
Yes,
Yeah.
it does.
So that's the first step, and that's the primary goal. And benefit in this case is often defined as the number of people whose lives can be saved. The number of lives saved is the benefit we want to provide to the population. Sometimes it's seen as the total number of life years, but that's a more complicated story, and I'm happy to talk about it in the question period. But for now, let's just focus on the fact that the primary goal has been to benefit the number of lives saved. And I would say coming up equal or next to that is the desire to do that in a way that ensures fairness for everybody. So the underlying ethical principle for these rationing schemes is to express a commitment to the equal worth of each individual. There is no life that is not worthy of being saved. And the idea is to come up with an operational procedure or a set of steps that can try to best maximize both those goals, solve for both those goals. Now, many state and hospital systems used a measure of how likely the person is to survive to discharge when they were thinking about lives saved, plus a quantitative score of what their longer term survival was likely to be. They were estimating how long they thought the person was likely to live for, say, another 5 years or so. And the problem, though, is that that was seen as discriminatory for the very reasons I just explained about the disproportionate impact on communities of color. If people of color have more underlying disease because of the early onset of chronic illness, they will have less likelihood of long-term survival from COVID. And long-term survival may also be discriminatory to some people with disabilities. So in response to that concern, my colleagues and I wrote a piece that came out in the New England Journal of Medicine in July, in which we called for a move away from long-term survival. And instead, we encouraged that we agreed that clinical benefit was what was important and that the number of lives to be saved was the goal. But we said that it was too discriminatory to use long-term survival and that we should only measure the chances that someone has to live 1 year post-hospital discharge. And also there are tools for measuring that provide a much more accurate picture than guesses about longer-term survival. And so we published that piece, and I hope it's had an effect. I think that there are more systems now that are changing their estimates. There's also procedural safeguards that are built into these guidelines. For example, each hospital has designated a triage committee, and it's usually headed by a physician, but not a doctor involved in the patient's direct care. It's seen as important to keep the treatment team separate from the triage team. And there's a couple of reasons for that. First of all, if they are separate, the treatment team can continue advocating for their patient, which is the role that doctors are socialized to do and what they feel committed to. And if they're asked to have to make population level decisions, they experience enormous moral distress. So for the physician and healthcare team, nurses and social workers and others involved, separating this decision is important for their own well-being. And the second reason is that triage teams should be blinded to the demographics of the patients under consideration. They shouldn't know the person's race or sex or socioeconomic status or immigration status. And so this is another way of sort of color blinding, if you will, the triage team, so that everybody is seen as having equal moral worth and there's less opportunity for bias to slip in. So I think maybe that's where I'll stop. Basically, the effort behind all these rationing schemes is just that. It's to honor the equal moral worth of all individuals while using the resources in ways that will save the most lives. So I'm going to stop there and let Brad take it over. Brad, you have questions for me?
Yes, I do. I mean, you were just mentioning the factors that the triage team shouldn't consider, and you mentioned race, religion, socioeconomic status, immigrant status. You didn't mention age. And I wonder whether you have any comments about whether younger people should be prioritized over older people. I'm sure not everybody here would be interested in that question, but some of us might be.
Yeah, that's a great question. So yes, age was missing from that list quite on purpose because it is controversial. And different guidelines in different health systems have handled this differently. And if you're interested, you can read about this. There have been papers in the New England Journal, in JAMA, but also on the Hastings Center blog, there's some very interesting papers. Larry Churchill is a philosopher who wrote a piece on why he would not want, why he would prioritize younger people. So I want to give that name, if I had a way to scribble it. Larry Churchill on the Hastings Center blog, it's called Bioethics Forum. And then Frank Miller also wrote a piece advocating that younger people be prioritized. So here's the thinking, that it is not because there's a sense that older people are less worthy of living. It's not a moral judgment about quality of life or about the worth of people at different ages. But the guidelines in which younger people are prioritized are very specific. They would only be prioritized as a tiebreaker. If all of the other factors I just mentioned, mainly short-term survivability, if all of those things were equal and there was no way to decide between these two people, then some commentators, including Larry and Frank, and I have to say I'm among them, so you can push back with me in the larger discussion. If it's a tiebreaker situation, I think there's justification to go with the younger person, not because the older person is less worthy, but because the younger person would be greater harmed by death at such an early age. The younger person would have what bioethicists colloquially talk about as fewer innings. They would have had a chance at life for much less time. And out of fairness almost, and the fact that they would be so much greater harm to die young than for an older person to die old, if you're in the tragic circumstance of a tiebreaker, I think it is justifiable to use that fact just to break the tie, not to go into it trying to privilege younger people, but only when we're pressed against the wall. There's also, to me, a common senseness about this, because I think if you talk to people, most most parents say that the worst experience for them ever, worse than their own death, would be the death of their child. So I think there's a kind of intuitive moral intuition we have about how sad and tragic the death of all deaths are, but of the death of a young person in particular. So that's my take on that, Brad.
Let me ask you one more question about this. You referred to your New England Journal piece and some of the concerns that had been raised by people with some disabilities about whether there was discrimination in the guidelines that were being developed. There's been a lot of outbreak of COVID in nursing homes, long-term care facilities. And there's a lot of people in those facilities that have dementia. Is having dementia something that should be considered if we were forced into some of these rationing decisions?
Yeah. So I'm going to give you my short answer, and then I'd like to be able to go back and say a little bit more about the context. So I would say that I would be opposed to making cognitive status or dementia one of the criteria for a hospital triage committee to consider. I think it's a very slippery slope to other kinds of disability and developmental disabilities and other things like that that might start to blur. But I do think it's important for all of us to think about what we would want if we had dementia, or if we were in the beginning or middle stages of dementia, and we developed a terminal illness or potentially terminal illness like COVID. Each of us has the right to refuse that ventilator, to refuse hospital care, to request palliative care. And so the presence of a deadly disease like COVID should be a stimulus for all of us to talk to our loved ones and say, well, there's not enough time now, because you'd have to already have known that you were in this situation. But in theory, and in practice, we should be having these conversations about what we would want if we thought that we were on a dementia trajectory. And in the United States, everybody has the right to refuse treatment of any kind, and can develop advanced care plans to indicate that they wouldn't want that. So, and our families can carry out those plans when we have lost capacity and we do have dementia. Designated surrogates, usually family or close friends, can carry that out. So this is something to think about, but I think it should remain at the family and individual level and shouldn't be written into the criteria for hospital systems.
Okay, thank you for that. I have a couple of questions about vaccines, but before I ask those, I think I'm going to ask, I see a number of people have posed questions, and Isabel Abola has been monitoring that, and I'm wondering if there are questions that sort of relate to what Millie has been talking about, Isabel, that you would want to bring up at this point.
Yeah, so there are a couple of questions that might actually play nicely to where I think you want to take the questions. One is that there's kind of interest in I think the political and the communal focus on allocation schemes for treatments. So for situations in which someone has already gotten COVID, they're already really sick. So why are we focusing on allocation there as opposed to thinking more about allocation and production of, for example, PPE or N95 masks in a way that can prevent COVID?
Totally agree. Absolutely agree. On March 13th, the Hastings Center published a letter that we, within 48 hours, we had 1,400 US bioethicists sign this letter calling on the federal government to use the Defense Production Act. The president had already invoked the act, so it could be used, but there was great reluctance on the part of the administration, which has continued until today, to adequately use the powers that the federal government has to produce the materials we need, like masks, protective equipment, and especially tests. We can't get back our economy until we have tests and can get results from tests quickly. So there was an opportunity to do that, and it just hasn't been exploited or used in any productive way. So I couldn't agree more. And that's why I was saying some shortages are just inevitable. I mean, no matter what you do, you're going to end up with a shortage. And unfortunately, then you turn to a rationing scheme. But as I said in the beginning, there were some of these shortages that were just man-made. There were failures of people and failures of government, failures to take action. And those are of a different order of moral concern to me. They're a real missed opportunity to have expressed responsibility.
We have a real rationing situation coming up with vaccine development, and I'm going to ask you about that. But before I do, I want to make sure, see if Isabel has anything else that is on the theme that we've been developing here.
Yeah, I would add one more question that kind of gets at the political and economic concerns. So some people are interested, you've talked about what a triage committee looks like for hospitals that are well-resourced, that maybe serve large populations, but there's some interest in smaller hospitals and in hospitals in rural settings. So how are those hospitals managing that either don't have enough people to comprise a triage committee, or where there's a huge doctor shortage? Kind of what is going on with them in this pandemic and regarding triage?
Well, they're more likely to need help with the missing resources, like the ventilators. And I know that one of the reasons we avoided crisis standards of care during the ventilator shortage was that states did take a look at where the needs were within the state, and they found ways to move equipment between systems. So you need an active public health infrastructure, a strong State Department of Public Health, and a willingness, a generosity on the part of the leaders of the large, well-endowed systems to be willing to share. There's a really great story from Massachusetts General Hospital when, I hope I have the hospital right, I'm pretty sure it was MGH, but it was one of the major hospitals in Boston. Yeah, it was MGH. And that hospital got an enormous amount of remdesivir, and they realized it was much more than they would ever need under any imaginable scenario. And so the leader there identified institutions that had gotten short shrift and moved some of his supply to the other institution in Boston. So I think there's no escaping good citizenship.
Well, let's turn to the vaccine question, because there we're without question going to have to initially make some priority decisions. I don't know what we'd call it rationing, but they'll certainly be priority decisions. So how do you, or how are the bioethicists community thinking about this question?
Right.
With the vaccines.
There is a lot of active discussion about this right now, as you can imagine. So the general sense, there's growing support for the idea that healthcare professionals should go first, and those who are most vulnerable should go first, like essential workers, like people driving buses, delivering our food, the people at the grocery checkout, people who work in meat packing. And here's the argument. The argument for both the healthcare professionals and the essential workers, well, basically there's a reciprocity argument and there's a kind of instrumental argument. The instrumental argument is that these people, both healthcare professionals and these essential workers, are keeping the rest of us going. And if they get sick, then no, there's not going to be any societal infrastructure. And we saw that when healthcare professionals were getting sick and dying in those first weeks here in New York. It was just terrible. And there were huge shortages of care for people. So there's this instrumental reason that we need to, for society's sake, we need to privilege them. And the other argument is that they're taking greater risks on our behalf. So it's a reciprocity argument that we should reward that risk taking and generosity on their part by acknowledging giving them some special privilege. So for those two reasons, they're at the top of the list. Of course, the other factor with vaccines that's being discussed is who's most likely to be harmed if they get sick, or who's most vulnerable to the disease, such as older people. And so many people are saying near the top of the list should be older Americans, where the consequences of catching this are much more severe, including people in congregate settings like nursing homes, and then other people in congregate settings like detention centers and prisons where the disease can just, go unchecked. I think there's very solid reasons there, and there's a lot of people writing on that. I'm a little bit of an outlier, and I'm not going to defend this. I'm just going to frame it more as a question. I'm a little concerned about prioritizing everybody over 65 and acting like kids don't have any long-term health consequences when we don't really know whether we might be harming the whole next generation, even though they may not get as sick in the moment. There are some quite distressing concerns about systemic effects on kids overall. So I think we need to know a little bit more about the harms to both groups, but that's the basic principle, that you would do first the essential workers and healthcare providers who the society needs to protect and who have put themselves at extra risk, and then you look at the people most likely to be harmed, and most people would say that's people over 65 and those in congregate settings. And they become the next level down. And then of course the rest of us. So there's going to be a long period of time, even in the best case scenario where we do have an effective vaccine, there is going to be a long wait, and we're going to have to put some kind of allocation scheme in place.
Well, let's get one more vaccine question, and then I'll go back to Isabel after that. And that is this question of a trade-off in the speed of which we're developing a vaccine, or could be new therapies as well. And do you see is there a trade-off between speed and safety in developing new vaccines or therapies?
Yes, there is, and I think we have to be very careful. So convalescent plasma is a cautionary tale. Just, I don't know, my sense of time has now been affected by this pandemic, so I'm not sure exactly when we had that sudden emergency use authorization for convalescent plasma. It's great that we can use emergency authorizations to make promising drugs available before they're proven, but there's also problems with that, because once you do that, you undermine the ability to hold trials. And who's going to sign up for a trial or even stay in a trial if they know that they can get something that looks like it might be promising? And many people are extremely distressed that we did that with convalescent plasma, because there were trials all around and now they're being undermined. So we may never know whether it works for COVID or not. So being too quick to lift regulations and authorize things under emergency circumstances can really undermine us in terms of ever finding out for sure what works and what doesn't work. And then of course, that affects people's trust and their willingness to take these meds and vaccines when they are made available. And I think we're seeing that with vaccines already, that people are already saying that they don't trust them, they're not going to trust them. That's one part. The other way I would answer that, Brad, is that there are ways we can speed development of vaccines. Very ethically challenging way to do it that some bioethicists are supporting, and it's something we could talk about with this group and see what people think. And that's the concept of challenge trials, where the usual way you would develop a vaccine is you have a promising agent, you vaccinate people, and then you watch over time what happens to the rate of disease incidence in those people who were vaccinated versus those who weren't. Of course, doing that takes years because not everybody catches something right away, so you have to play that out. One way to speed that up is to do what are called challenge trials. In a challenge trial, you do something extraordinary, something that in bioethics we would never approve, and that is you take people who have received the experimental vaccine. You don't know whether it works yet or not, but you've given them something that you think is promising. You're trying to test it out, and then you purposely expose them to the disease. Now, we've done that a few times. I think we've done it for cholera and for one other disease, but only for diseases for which there was a rescue medicine or a rescue technique. And and only if people are fully informed that we don't know if this vaccine has worked and you may get very sick. So fully informed consent and a rescue if it goes badly have been the terms. But some people are saying that for the sake of speed, we should do challenge trials, fully informed, make sure people know that we are not going to be able to rescue you because we don't have a treatment yet. So that would be one way to speed up the whole process that would not, unlike emergency use authorizations, it wouldn't undermine our knowledge. We would still be, it's still a very sound way to learn what works and what doesn't work. And it would also speed things up, but it would put some human volunteers in harm's way.
Isabel, can I pass it back to you for questions from our group here?
Sure. So while we're on the topic of vaccine trials, there's some interest in kind of querying why some older adults are excluded from phase 3 vaccine trials. So that is, the latest and largest scale vaccine trials, and whether that's right, whether that might itself be a form of age discrimination and all of those kind of types of concerns.
Yeah, and some people are also worried that people of color are being not excluded, but not being recruited as aggressively as they should, so that they're not being represented. And then we can't find out if the vaccine works as well for older people or for people of color if they haven't been included in the trials. I think this is an issue of safety. I mean, some people feel that informed consent isn't enough, that scientists should not put people in harm's way. Even if they're willing to be put in harm's way. I mean, we're also not including pregnant women. And Ruth Faden and other people have written about that as discriminating against them, because then we won't know whether these things work for them or not. So I think it comes from a good place of wanting to protect the most vulnerable, but the consequence of that is that we limit our knowledge about how to help the most vulnerable.
More?
I would add to do a little bit of a right turn to talk about what you went over earlier in the presentation. There have been a couple of mentions of interest in kind of racial disparities, and particularly what's going on with the Black community and the really high rates of COVID. And I think that there's interest in understanding two things. One is what's causing this. You talked a little bit about the social determinants of health, but specifically for COVID, what's causing this? One person was wondering if it was epigenetics or kind of what other roles might be going on. And the second question is kind of what can we do about that? Now that we're in this situation, now that an unequal society has created unequal outcomes, is there anything we can do?
So I'm really grateful for the question. And I think that's exactly what all of us should be asking. I mean, I don't think it's anything unique to COVID. I think that COVID has just happened. This has happened on a scale, phenomenal scale. And it is a lethal disease, so the rates are very high. But egregious differences in longevity and in the timing of chronic illness have been known for a really long time. We've known this for a really long time. Nancy Krieger is a professor of public health at the Chan School of Public Health. She recently wrote a piece where she said, it's just unconscionable for us to keep on doing studies that are documenting these differences, but then not organizing ourselves to do anything to remedy it. The remedies are to some extent political decisions. We know that people who live in better housing, who have higher incomes, who have better education are healthier. And so there's a direct link to whether or not we increase the minimum wage, for example. How much we invest in what the Robert Wood Johnson Foundation is calling communities of opportunity, where they are trying to take a holistic community approach to changing lots of things within that community simultaneously to kind of change the ecosystem. And they've been giving grants to try to have local communities working also with experts to develop major transformations at the local level. That's another example. We still have huge amounts of lead poisoning. Brad mentioned at the beginning that I run a fellowship at Harvard Medical School for physicians working in the Harvard teaching hospitals. And we had I had a fellow in that program who shared in a very personal way how most of his family has been brain damaged by growing up in cities with lead, with water in the lead because of old and rusting pipes. So I think we, as a society, this is a moment where that we could grasp, and it would be, if there's anything good to come out of this terrible disease, it would be to awaken us to ways that we can start to try to address something we've known a lot about before, but it was kind of possible to look the other way. And now it's a whole lot harder to look the other way.
Millie, I have two more questions for you. I'm going to tell you what they both are so that you save enough time to get to the second one, because the first one could take time.
Okay.
The last one I'm going to ask is just to talk about the Hastings Center a little bit and what you've been doing in with regard to the pandemic. There's just what's been happening there. So save time for that. But the other question I want to ask is that the field of bioethics grew up with a strongly individualistic point of view. That is, we had the most famous of the Tuskegee syphilis study, and we can go back to Nuremberg, and the importance of informed consent. The individual rights, a very strong a feeling of individual rights in the origins of bioethics.
Yes.
And now we have a situation where people are being asked to wear masks and things that some people see as encroachment on liberty. So how's the field of bioethics handled this shift away from the primacy of the individual and the individual rights?
Okay, I see why you told me to save time. Really provocative question. I'm not sure where to begin to unpack it. So yes, American bioethics in particular has had a special focus on individual rights. It started in a way, you could almost say, as a patient-centered effort to redress, paternalistic healthcare, and was akin to many other things that were happening in the 60s. It grew up in the late 60s and early 70s, and just as part of this, you could see it as part of the civil rights movement in a way. So yes, we focused a lot on individual rights because we had a very paternalistic system, and we were trying to trying to build a system that was more responsive to individuals. We wanted individuals to be able to make their own treatment decisions, especially around end-of-life care. It used to be uncertain whether you could unplug a ventilator, and we've made it very clear that patients and families have that right. That's very different than bioethics in other places in the world. And not only different in Asia, where there's more focus on communitarian concerns, but also in Europe, where the concept of solidarity is prominent. And that's a word that's almost never used here to talk about what we owe each other and how we can build a common good. So yes, American bioethics has been skewed, but I understand why, and I've appreciated its focus on individual rights. What I think we're seeing right now with the pushback against masks is conceptually very confused, as well as being damaging to our public health. It's conceptually confused. Liberty was never conceived of as license. And I think John Stuart Mill, I think there's this iconic reminder always that he said, you can bat your arms in any direction you want, except it has to stop when it hits my nose. And even the earliest people writing about liberty, John Locke, even before him, before Stuart Mill, wrote about how liberty does not mean license. Liberty ends when we harm other people. Wearing a mask protects other people. Not wearing a mask harms them. And so it makes me very sad, and I think it's also frightening to see people believing that their arguments against acting together with some solidarity to conquer a common enemy, this virus, is somehow an encroachment on liberty. I think it's a false understanding of liberty.
Okay, you have about 5 minutes to respond to the question of how a bioethics center that has been around for 50 years is presented with something new in February of this year. COVID and what's happened there as a result?
So we are mainly funded by philanthropy and by grants. And the grants come from the National Institutes of
You
Health,
want me to get it, Peter?
the National Science Foundation.
Yeah, I have gloves over here.
Somebody should mute, because we're here, background conversation. So we get funded by the very many federal agencies and by private foundations, and they're funding specific research projects on a wide array of really interesting and important questions. For example, right now we've got a project on chimera research, blending genes from animals with humans in order to create disease models. There's a partial hold on that kind of research at NIH, and we're trying to come up with guidelines that will enable it to go forward in an ethically appropriate way. We've had projects on human gene editing, a book that just came out on human germline editing. Many, many topics. Many of them are emerging biotechnologies, and others are focused on ethical issues in healthcare and healthcare delivery. For example, one of our scholars two of our scholars have focused on access to healthcare for immigrant populations. So science on the one hand and health on the other. And these are active research projects. They culminate in books and in special reports and in writing for the public. Increasingly, we are focusing on both new scholarship, research that is, and also writing about it and holding events like this one to bring those issues to the public as well. So all that was going on. And then our 50th came along and we said, well, how can we hold ourselves to an even higher standard? We want to up what we're doing in the public square, and we want to be able to respond to ethical issues, kind of breaking ethical issues as they are coming out in the news. Could we respond in real time, not just in the slower, more academic model of our scholarship, not that it's slow, but in the thoughtful, on a scale of a year or two to do the research projects? Is there a faster pace that would help the public understand breaking issues? And so because our 50th was coming up, we prioritized that. We put in place a special fund that we're growing to help us respond in real time, sort of a rapid response ethics rapid response. And we had all that in the process of being put in place when COVID broke. And so it was a real test of whether we could, do what we were hoping to do. I mean, COVID is obviously a tragedy for the nation, but it's been a real proof of concept for the Hastings Center. So we instantly organized. We did that letter to the White House, which I told you about at the beginning, where we got the entire community to sign and call for the use of the Defense Production Act. We have developed guidelines for hospitals as they were creating the triage committees. We started scholarly writing, like the New England Journal of Medicine piece. I did that in April. Nancy Berlinger has done 2 other projects to help health systems as they're grappling with these triage plans. We've launched a public webinar series. If you sign up for our e-newsletter, you'll see this webinar series. Actually, there's 2 series. The first one we've completed. It was on managing the pandemic, and you can see all these archived. It's something like what values, well, anyway, it's about managing what we're in, the midst of the problems we're in. The second one we've just started is on racism, health equity, and this moment in time. And that is addressing exactly the questions that somebody in the audience passed by Isabel just a few minutes ago about, well, what can we do about these racial differences? That webinar series is focusing exactly on that. And so public engagement through activities like that and additional scholarship. The last thing I would say, and I think I have a minute, is that we have reached out to scholars of color. There are bioethicists who study these issues from who are scholars of color themselves, but also asking a variety of questions of importance to the African American and Latino communities. And we have invited them into a series of conversations, and we are conceptualizing a sequel of 3 special reports that are going to look at issues that they feel are important for mainstream bioethics to be aware of. We're looking for funding for that right now.
Let me put the last slide up, if you would, Isabel, because it has it just has contact information. And there we go. There's a weekly newsletter. There's something called the Bioethics Forum, where various people, mostly scholars, write very short papers on controversial issues. There's the website and also the mailing address. Certainly urge anybody that finds this stuff interesting to get the Hastings Center on your radar.